Good afternoon, dear ladies and gentlemen. I would like to open our next plenary session, and it is my great pleasure to introduce our first speaker, Dr. Said Kashim Arikov from Uzbekistan. Thank you very much for your coming, and please your talk.
Good afternoon, dear chairman, ladies and gentlemen, colleagues. First of all, I want to say very many thanks to organization committee and personally to Andres Rubens for inviting me to this congress. And it is my presentation, and it is honor to me to make my presentation in such great audience. My report devoted mycosis or pubic area caused by zoophilic trichophytia. Me and my colleagues observed some patients, and I want to inform you about our cases. You know, fungal infections are among the most successful and widely distributed of microorganisms, with habitats ranging from lakes to the Arctic wastes. Fungal infections of the skin, nails, and hair are among the most common causes of the skin diseases in Uzbekistan and as well as USA, European countries, and other countries. In most cases, fungal infections are caused by dermatophytes such as Trichophyton, Microsporum, Epidermophyton, and the esters such as Candida albicans and Malassezia furfur. You know, transmission about fungus, up to 50% of human dermatophyte infections are contacted from animals, particularly in rural area. Trichophyton verrucosum from infected cattle, which cause pustular tinea barbae, tinea corporis lesions in man. Microsporum caries from infected dogs and cats, which cause tinea corporis and tinea capitis. Trichophyton ventriculitis from infected rodents, and Trichophyton erranceae from infected hedgehogs, which is rare but does occur. Trichophyton equinum from infected horses, which is also rare, but we can see in rural area. According to my experience, I see at present time in clinical cause of mycosis have some peculiarity, some feature. First of all, rejuvenation of mycosis. If some 10, 20 and more years ago, if we see mycosis in elder patients, now we diagnose it in young patients. At present time, we see frequent occurrence with skin diseases and frequent combination of several kinds of fungal infections and atypical cause. Maybe somebody will add some opinion, some clinical observation to this list. And I want to show you atypical cause of tinea corporis caused by Microsporum canis in this patient. Young dermatologist sent to our department patient who proposal diagnosis was psoriasis. In our country, like this Microsporum, we called Microsporum, but it is was similar for this doctor opinion. And in our clinic we observed and some cultural methods with diagnosis This is tinea corporis caused by Microsporium canis. And next feature is combination of dermatophytes and Candida albicans in one patient. You can see in the face and auricular areas of the skin lesions caused by Trichophyton rubrum, and onychomycosis caused by Trichophyton rubrum. Here you see in the penis Candida infection, and in corporis you can see tinea versicolor infections. And Trichophyton and Microsporium species are the more etiological agents of tinea capitis. In Uzbekistan, most common causative fungi of tinea capitis is Trichophyton verrucosa to compare with Microsporium. For example, for Russia, Microsporium, the most common causative fungi of tinea capitis. It is some differences. You know about clinical feature about tinea capitis, which caused by Trichophyton, and we usually see in children with patches of scalp hair loss and scarring. There is background erythema. The intensity of inflammation varies. Also, the zoophilic fungi usually produce more crusting and oozing. Here you can see pastels or abscesses we know as carrion or carrion cells symptom, which is an inflammatory response to the dermatophyte itself rather than secondary bacterial infection. The hair in the affected area usually retains, but the long infection persists, more than likely the alopecia will be permanent. Many patients have cervical or posterior lymphadenopathy. Severity of itching is very variable. It is, I showed you, it is typical clinical picture which we see in our everyday practice. And I want to start about some history. It is first observation of mycosis of pubic area caused by zoophilic trichophytia. In 2002, we met with infection, atypical localization in pubic area, and we thought it is only one case, but patient came and number of patients increased. And we observed 356 patients with fungal infection caused by Trichophyton verrucosum in our department during the 1 year. You see here, man was 66%, woman 33%. Children was approximately 40% with classical duration, tinea capitis. Among these patients, we saw 60 patients, adult patients, and in this patient, lesions were localized in pubic area. After that, every year, year to year, we observed some patients, and 2013, we see approximately 418 patients. And year to year, increased number of patients with mycosis of pubic area. And for observation, we used microscopic and cultural method for identification of fungi as sub-laboratory tests for detection of sexual transmitted infection. And here you see age of our patients, and we observed more patients, more than 83 28% of patients in sexual active ages, 21 to 30. And during the observation, we asked about the reason of this infection. And patients said 85% of cases has been linked to sexual contact, and 50% of patients could not indicate reason. But some patients proposed through the hands, shaving machines. And one lady, a woman, said me, talking tete-a-tete, about she worked in big market, in market very crowded, and in markets selling cats and sheep. And he did some services, selling some foods, breads, and some prepared some foods. And for keeping to this money, he put in very safety place, in public area. I think through this money, maybe she was infected. It is from the patient's words. And according to the clinical cause, we divided patient in 3 groups. First of all, superficial type of inflammation reaction. It is in 6 patients we see. Infiltrated lesion we see in 28% of patients, and pastel or carrion lesions was seen in 65%. And in all patients, we found Trichophyta ectotrichis by microscopic investigation, and Trichophyta verrucosum was revealed in 48% of patients using of cultural method. You can see, for example, superficial type of infection. It is here, there is erythema, scarring, and this man was infected from her husband, from her wife, and wife had at that time carrion type lesions. Carrion type lesions has this wife. And here infiltrated lesions we see in 28% of patients, and pustules and carrion lesion in pubic area and in pubic area. And according to the localization, not only pubic and another side, we divided patients into 3 groups. First group, localization was only in pubic area, 21% of patients, and pubic area plus body, buttock, thighs, etc. It was more patients, 72% of patients. And third group, pubic area and extragenital areas such as arms, hands, face, 6%. You can see in pubic area only localized. Here, pubic area with crusting and pastels. Here, pubic area and left thigh. Here, pubic area and right thigh, and also pubic area and right thigh. Here, pubic area, first of all, was infected, then left thumb was infected. Here, we see in pubic area in patient and in face. Here, pubic area, and in this patient we saw infection area was upper lip. Here in this woman, you see in pubic area some pastels, crusting, and in the neck inflammation stage of disease. Here in pubic area and hands, right hands, and in pubic area and corner of right eyelids and perineum. And in gynecological observation, we saw all perineum was affected and labia major infected too. It is interestingly, this patient M, he is husband of patient D. His husband, he was first infected, and he infected his husband, and you see here third stage, crust and pustules, and here only started these pustules after he's infected from his husband. It was interesting observation of our patient for sexual transmitted infection, and you can see here we found in 83% of patients some sexually transmitted infections, and here Candida albicans and Trichomonas vaginalis and chlamydia and etc. infection. In 5 cases, it was pubic area infection, syphilis, and chlamydia trachomatis. In 4 patients, we find positive for HIV infection, gonorrhea, and Trichomonas vaginalis. And after these cases, I wrote a letter to European WHO, and they studied these cases in the world, and they said there is no information about Trichophyton ectoteris localized in pubic area, and according to the recommendation of European WHO, we included to the list of sexual transmitted infection this mycosis. And for the treatment in mycology, especially for tinea capitis, using some drugs and grisifulvin in micro size and ultra micro size form. You know, grisifulvin is gold standard for the treating tinea capitis, especially in children and adults too. But it has some side effects and long duration treatment. It has some failures, and now we have more effective preparates, terbinafine and itraconazole. In our study investigation, we used terbinafine. And terbinafine was given 1 tablet a day. All our patients was above 40 kilogram, 250 milligram per day. And patient was received this preparat during the 4 weeks. You can see here baseline, and we did mycological investigation after 2 weeks, 4 weeks, and follow up at the end of 8 weeks. Here, mycological cure rate and clinical cure rate increased, and at the end of week 8, we obtained 91% of mycological cure rate and 96% clinical cure rate. According to this investigation, we can conclusion Trichophyton ectoteris causes not only tinea capitis, but it can affect other parts of body, like pubic area. And Trichophyton ectoteris in pubic area can be transmitted by sexual contact and associated with other STI. And mycosis of pubic area caused by trichophyton ectotrix may be another type of trichophyton can be included in sexual transmitted list. Thank you for your attention.
Thank you very much for a very interesting presentation. Now we have time for one short question, please. Thank you.
Thank you.
So now it is my pleasure to introduce Professor Chong-Hung Hu to the next lecture, please.
Good afternoon, Madam Chairpersons, President Rubins, and dear colleagues. I would like to discuss with you a particular issue, which is adult onset immunodeficiency syndrome with you. First, I would like to share with a patient we observed recently. And before I start my talk, I'd like to thank President Professor Rubins invite us to come so far away to what's the name of the city? Riga. I'm from Taipei Medical University, Taiwan, and this time we have sent a delegation of myself and Professor Lin. You want to stand up so we can see you, and Professor Lan. And Professor Lan gives a very nice talk this morning. I'm sure you heard about the phototherapies. And also, I want to report to you, Taiwanese Dermatologic Association signed an agreement on the academic and professional partnership with the Baltic Association of Dermatovenerologists. And we hope that in the future, the Pacific Ocean and the Baltic Sea may be far away, but dermatology will bring us together. Okay, I started my talk. Before discuss this new disease, new syndrome, let's go back to the last century in the 1980s. And this was the patient I saw in my career, the first AIDS patient that I saw when I was at Stanford University. I remember this patient was coming from San Francisco, come to us with about 3 months history of this generalized dusky erythematous nodules. We did not know what they were. Then, by doing the biopsy, we knew that was Kaposi sarcoma, which is quite unusual at that point. And in the following about 3 to 6 months, we see more patients. This is the same patient in the back. And this is another patient, more like another Kaposi sarcoma. So this was 30 years ago. I'm sure Professor Kaposi will know where this is something different from classic Kaposi sarcoma. And as you remember, maybe younger colleagues here may not know about the history. Within about 2-3 years, we know this is a retrovirus. It's the HIV, retrovirus, and it infects the T cells and with infection and with the tumors. That was the history of the last century, the 80s, almost 30 years ago. Now, I'd like to discuss with you this new findings, new issue. It's called adult onset immunodeficiency syndrome, which the key player is the anti-interferon gamma autoantibodies. And infection cause usually is the non-tuberculosis mycobacteria. And it was, the first one was in 2004, exactly 10 years ago. Now, the first patient actually was reported in the Journal of Blood. And guess where this report was from? It actually was from Europe. It was from the Charité University Hospital in Berlin in 2004. An interesting thing is this patient was a 25 years old woman from Thailand. She was living I'm sure she was in Berlin for about 8 years. And she had a very complicated and long suffering story, including pneumonias, tonsillitis, osteomyelitis, and lymph node biopsy from cervical, the neck. It shows a neutrophilic predominant. It's called necrotizing lymphodenitis. And for the skin lesion, she did have a multiple pustular lesion on the thighs. And finally, they did a bone marrow aspiration, and the culture grew Mycobacterium caroni. So this was ordinary non-tuberculosis Mycobacterium infection. However, it was the first report of this patient, this lady, did have anti-interferon gamma autoantibodies. And more specifically, it's the IgG4, which is also important. Subtypes of IgG make some difference. 1 year later, because this was in Europe, was a single case, was a lady from Thailand, from Asia. So 1 year later, in NIH in the United States, they discussed two groups of patients, altogether about 35 patients, and they all have the non-tuberculosis, NTM, non-tuberculosis mycobacteria. And the first group was disseminated, meaning the multi-organs involvement. And the other group is just the lung. Among all these 35 patients, actually about 80% were women, which is an important features of these syndromes. And interestingly, they found 6 patients, they're all women, also has this anti-interferon gamma autoantibodies, but none occurred in the pulmonary NTM, only occurred in the disseminated multi-organ NTM, and all women, all patients, all from the Southeast Asia. So, with this background, I'd like to share with you the patient we saw in last year or so. And this patient, this lady, is also a woman, a Taiwanese woman, who was born and lived in Taiwan for all her life. And she was 51 years old. The final diagnosis about this patient actually involved almost 6 months. And she went through 3 different hospitals without definite diagnosis. And finally, to make the story short, she did have a typical non-tuberculosis disseminated NTM. And also she has the anti-interferon gamma autoantibodies. Now, she had the initial problem was recurrent painful erythematous nodules on the legs. Of course, the first diagnosis could be erythema nodosum or erythema induratum, or those the leg, painful leg. And she also has fever. So she was in first hospital, was our hospital, one of our hospitals of our university. And she did respond, of course, multiple tests did not show anything, except the skin biopsy did show this is the lesion. Not very impressive, but they were tender, they were erythematous, they were multiple. another lesion on the foot. And the biopsy did not show mainly the pathology, the changes was in the subcutaneous fat. And this is the lobules, not the septal panicularis. And the infiltration mainly are neutrophils, predominantly, overwhelmingly neutrophil, non-lymphocytic. Another one, and some eosinophils also. So the histopathologic diagnosis was lobular neutrophilic panicularis. So at this point, our colleagues were dealing with a patient with recurrent fever with lobular neutrophilic panicularis. But all the cultures did not reveal anything. However, she did respond to the antibiotics, IV antibiotics, temporarily for a couple of days. Then after about 4 days, her fever will come back again. So, okay, we don't need this really. All right, so she was discharged. In the next 3 months, she went to different hospitals, was hospitalized for about 3 weeks, went through all the tests. But again, this time, because she also has fever, she had leukocytosis, thrombocytosis, and at this point, she did show the cervical lymph node was painful, was enlarged. And all the autoimmune profile, EBV and cytomegalovirus and tumor markers are negative. You may wonder why we do the EBV, because in our part of the world, the nasopharyngeal carcinoma, NPC, was quite common. So with the cervical lymph node, we usually have to do the EBV, the titers. And bone marrow only showed reactive hyperplasia. At that point, she was in the second hospital. They didn't pay attention to the cervical lymph node, except that they did not do the biopsy. They only did the aspiration. So the sample was too small. So cannot culture, cannot do any smears. So she was discharged with a diagnosis of, because she has fever, she has the neutrophilic panicularis. So the diagnosis at that point was Sweet syndrome, that's all. And for some reason, she was discharged and followed up in the rheumatology outpatient. Not interestingly, it's quite peculiar. She had a drug reaction to Plaquenil because the rheumatologist was treating her problem as Sweet syndrome, subcutaneous Sweet syndrome, with a proper steroid and Plaquenil. And she had drug eruption to the Plaquenil. So she decided that she didn't want to take the medicine anymore. So she went home. And after Christmas, after New Year, in February, she came back to our second hospital. We have our university has 3 hospitals, another hospital. At this point, she went through fever again, weight loss of about 15 kilograms. She has dyspnea, cervical lymph node getting bigger, and higher lymph node and pleural effusion. So she did have trouble with all this. This is the lymph node. And higher node. All right, so we did insist we need to do a biopsy, not aspiration. So the SFR stain was positive for the pathology, but non-granulomatous changes. However, the culture did grow mycobacterium abscesses. So here's another non-tuberculosis mycobacteria. And we started the treatment of all this. There's some SFR stain. Okay, so we placed him on amikamycin intravenously for about 2 months, and followed by the doxycycline and other antibiotics. So her lymph node get better, fever did subside, and however, the fever sometimes did come back. So we know this is a disease very difficult to treat. At this point, we know we are dealing with something, we been seen in the Southeast Asia. So to make the story short, we did find a high titer of anti-interferon gamma antibody, autoantibody in this lady. So she fits into the so-called adult onset immunodeficiency syndrome. Now, I just want to show you the so-called switch syndrome, subcutaneous switch syndrome with the NTM, disseminated NTM. Actually, in the 1990s, in the last century, actually 20 years ago, did report. The first report was a report also from Taiwan, National Taiwan University, my colleague, Dr. Chu. And 1 year later, also from Thailand, the same kind of problem. So this was neutrophilic dermatosis. At that point, it was called switch syndrome. Now, I'd like to share with you one, probably the most important paper until this point. It was 2 years ago in New England Journal of Medicine, was the leading article. They reported 200 patients, both from, mainly from Thailand and some from Taiwan. By the way, these are two different countries, not the same country. As you know, Thailand is in, I'm sure you know where Thailand is. Thailand is in Bangkok. It's in the Indo-China Peninsula, near Vietnam. Taiwan, our country, actually is in Pacific Ocean, near mainland China. So, but this disease is commonly seen in these two, Thailand and Taiwan. They are different countries. Now, for this about 200 patients, they did find, that paper did find the autoantibody, anti-interferon gamma autoantibodies in the disseminated form, or NTM, about 80%. If you have second infections, in other words, disseminated NTM and another infection, about almost 100%. Then this is also disseminated TB, not just pulmonary TB, about 11%. And the lung pulmonary TB is about only 2%. Healthy about patient control about 2%. So this autoantibody did occur in a small percentage of normal individuals, but usually a low titer. And those in this NTM, disseminated NTM infection, usually a high titer. So the topic of my talk was the adult onset immunodeficiency syndrome. Why is it important for dermatology? Well, as you know, the discovery of anti-cytokine autoantibodies is a very fascinating issue, fascinating field. And secondly, this syndrome, almost 80%, or probably more than 80% of patients would at some point would have the skin lesions, and quite commonly are the first signs of skin lesions. So, it's important for us. And our ancestors always told us. And again, all right. Now, the take-home message is, these new syndromes, until this point, it's mainly occurred in the Southeast Asia. But with the globalization of the current situation, the travel, international travel is so often, the immigration is so often. So you may see this patient in this part of the world someday. And the key point is, when we're dealing with so-called FEO, meaning the fever of unknown origins, in the past, we can spend a lot of time without knowing what happened. And one striking feature is cervical lymph node. You almost, high percentage of patients with cervical lymph node. And usually the diagnosis, the positive cultures are from the biopsy, not aspiration of cervical lymph node. And for the skin, when we are dealing with neutrophilic dermatosis, anything from switch syndrome to the neutrophilic panniculitis or the pustules, even the other pustular lesions, we have to think about these lesions. And culture from a lymph node. because usually none from the skin. Of course, this syndrome, almost more than 80% or 90% are in the women. So there's maybe some gender specificity, and also in the Southeast Asia. But once again, I'd like to share with you that this syndrome may someday you can see this in this part of the world. Now, this is the university that I work with. Now we have 3 different hospitals, and that patient actually first was in our university hospital, and the second hospital was in different hospital, not in these pictures. And finally, she came back to another hospital, than the Wanfang Hospital, which is a city hospital, but we run the hospitals. So the diagnosis was made in our city hospital. And as you probably know, this is called 101 building. Used to be the tallest building in the world, but not anymore. Now probably the second tallest or the third tallest. And our campus is in 10 minutes walking distance from 101. Actually, it's in the downtown Taipei. And I hope we can see you in Taipei, and hope our paths will cross again. Thank you very much.
And there is time for 1 or 2 short questions. Oh, I welcome Professor Rubins on the stage.
It is my pleasure to hand Professor Chong Hon-Hu, Honorary Member of Baltic Association, about your input in
And now I introduce to you with our next speaker, Dr. Kenji Takamori from Japan, and he will talk about itch in atopic dermatitis. Please, doctor.
Ladies and gentlemen, it is my pleasure to present here. I would like to express my sincere thanks to Professor Robin for inviting me to this Congress. From now, I would like to talk about recent topics of itch in atopic dermatitis. Properties of itch in atopic dermatitis. Itch is induced by an ordinary non-pruritic stimuli. Strong itch is induced by weak pruritic stimuli. These findings suggest atopic dermatitis skin is sensitive skin. Itch is induced by pain stimuli. Itch is not relieved by antihistamine. This type of itch is called intractable itch. Proposed mechanisms of antihistamine-resistant itch. Participation of chemical mediators other than histamine. Proteases such as tryptase, catepsin S, eosinophil products, substance P, and cytokines such as IL-1, 2, 31, TNF-alpha, and TSLP. Second, involvement of histamine H4 receptors in itch. Third, abnormal itch perception caused by increased epidermal nerve density. Fourth, opioid receptor mediated itch. Activation of mu opioid system induce itch. On the other hand, activation of kappa opioid system induces the suppression of itch. Proposed itch-related factors in atopic dermatitis are substance P, CGRP, epidermal nerve fibers, part tryptase system, TRPV, MRGPRS, GRP systems, NPPB, opioid, cannabinoid, cytokines such as IL-31, TSLP, and histamine H2 receptor. Recently, IL-31, TSLP, and H2 receptor are focused as new itch-related factors. Epidermal nerve fiber is easily stimulated by exogenous new pruritogens such as physical, chemical, biological stimuli, and also epidermal nerve fiber stimulated by products from keratinocyte and immune cells. The signal of excitation of nerve fibers transfer to the brain through spinal cord, and then itch recognized. Today, I would like to talk about three topics. First, regulatory mechanisms of epidermal nerve fibers in atopic dermatitis. Second, semaphorine 3A as a therapeutic target for atopic dermatitis. Third, new anti-pruritic treatments. I would like to talk about the role of epidermal nerve fiber in itch. Distribution of nerve fibers in normal healthy skin, the nerve fiber mainly located in the dermis and terminate around the dermo-epidermal junction. In atopic dermatitis skin, the nerve fiber penetrate into the epidermis. Sun and Chen reported gastrin-releasing peptide receptor mediates the itch sensation in the spinal cord. GRP positive nerve fiber, specific fiber to the itch sensation, not responsible for pain. This slide shows the GRP positive nerve fibers in epidermis. Yellow shown the GRP positive nerve fiber. This nerve fiber, itch specific fibers. The percentage of GRP positive nerve fiber is 18 to 20%. Epidermal nerve density is regulated by nerve elongation factors such as NGF, anhydroglycan gelatinase, and nerve epidermal nerve repulsion factors such as semaphorine 3A and anosmin 1. Out of these factors, NGF and semaphorine 3A is most important for the regulation of epidermal nerve densities. Expression of semaphorine 3A in healthy, normal healthy skin can be seen. In atopic dermatitis skin, expression of semaphorine 3A decreased significantly. This slide shows the expression level of semaphorine 3A messenger RNA. As you can see, the expression of semaphorine 3A messenger RNA significantly decreased compared to the normal healthy skin. This slide shows the relationship between semaphorine 3A and nerve fibers. In normal healthy skin, the abundant semaphorine 3A expression can be seen. In this time, the nerve fiber located on the dermis. On the other hand, in atopic dermatitis skin, the expression of semaphorine 3A significantly decreased. In this time, nerve fiber penetrate into the epidermis. Semaphorine 3 expression significantly decreased in atopic dermatitis skin compared to the normal healthy skin. On the other hand, NGF expression is increased in atopic dermatitis compared to the normal healthy skin. A possible mechanism of modulation of epidermal nerve density in atopic dermatitis. In healthy skin, nerve repulsion factors such as semaphorine 3A more dominant than nerve elongation factors such as NGF. In this time, nerve fiber cannot penetrate into the epidermis. In atopic skin, nerve elongation factors such as NGF more dominant than nerve repulsion factors such as semaphorine 3A. In this case, nerve fiber penetrate into the epidermis. Next question is, how do nerve fiber penetrate into the basement membrane? Normal healthy skin, nerve fiber terminate around the basement membrane zone. In atopic skin, the nerve fiber penetrate into the epidermis. The nerve fiber may be, as you can see, the basement membrane main component is type 4 collagen. So I think nerve fiber penetrate into the epidermis using the type 4 collagenase. Experimental result shows nerve fiber penetrate basement membrane by type 4 collagenase such as matrix metalloproteinase 2 on growth cones. Matrix metalloproteinase distributed in the growth cone. Thus, nerve fiber penetrate into the epidermis using the matrix metalloproteinase 2. From now, I would like to talk about management of intractable itch in atopic dermatitis, targeting epidermal nerve fibers. Effect of emollient and UV-based therapy on epidermal nerve fibers was investigated. As you can see, the PUVA therapy suppressed the itch of atopic dermatitis. Before PUVA treatment, as you can see, the expression of semaphorine 3A decreased significantly in atopic dermatitis. After the PUVA treatment, semaphorine 3A expression restored to normal level. This slide shows the effect of PUVA, narrowband UVB, and eczema lamp on intraepidermal nerve fibers. PUVA therapy and narrowband UVB and eczema lamp decrease the intraepidermal nerve fiber, especially narrowband UVB and eczema lamp is significantly decreased the intraepidermal nerve fibers. This slide shows the effect of emollient in epidermal nerve fibers. Topical emollient decreased the number of epidermal nerve fiber, especially the heparinoid is effective. Before treatment, nerve fiber penetrate into the epidermis in atopic dermatitis. After the treatment, emollient UV-based therapy, the nerve fiber disappeared. And the reason is that emollient and UV-based therapy induce the semaphorine 3A in keratinocyte. This is a summary of treatment. Emollient, topical application of emollient prevent dry skin inducible intraepidermal nerve growth. and UV-based therapy inhibit the dry skin-inducible nerve growth. From now, I would like to talk about semaphorin 3A as a therapeutic target for atopic dermatitis. Therapeutic strategy, semaphorin 3A expression in AD epidermis is decreased. The rescue of semaphorin 3A function may reduce the epidermal nerve density and attenuate itching. This slide shows a picture of AD-like atopic dermatitis-like skin lesion in NCA mice. AD-like skin lesion was induced by repeated application of mitoallergen. Semaphorin 3A ointment were applied on this skin lesion once a day for 4 days. And epidermal nerve fibers, scratching behavior, transepidermal water loss, dermatitis, inflammatory cell infiltration were investigated. This slide shows nerve fibers. PGP 9.5 positive nerve fibers and substance P positive nerve fibers. Both fibers decreased by semaphorin 3A ointment. This slide shows scratching behavior. Scratching behavior also decreased by ointment of semaphorin 3A. This slide shows transepidermal water loss. Transepidermal loss also decreased by semaphorin 3A ointment. This meaning semaphorin 3A ointment improved the skin barrier functions. Dermatitis. The effect of dermatitis on semaphorin 3A improved the dermatitis, as well as betamethasone and tacrolimus. Semaphorin 3A ointment reduced the number of CD4 T cells and eosinophils, and acanthosis also improved. This is a summary. Semaphorin 3A ointment on the atopic dermatitis skin lesion shows reduction of epidermal nerve density and attenuation of itch, recovery of skin barrier, and finally, dermatitis was improved. From now, I would like to talk about the control of endogenous semaphorin 3A in human keratinocyte. Identification of promoter region of human semaphorin 3A. Regulatory region of semaphorin 3A gene was inserted to vector, and the promoter region and transcriptional factor identified by Lucier's assay. The characterization of transcriptional factor binding site in the semaphorin 3A promoter. The binding site of ROR alpha is the most important site in semaphorin 3A expression. Semaphorin 3A expression was increased by ROR alpha agonists such as SR1078 and cholesterol sulfate. Semaphorin 3A expression was inhibited by ROR alpha antagonist. Activation of ROR alpha may induce semaphorin 3A expression in keratinocytes, Now we are searching alpha agonist for clinical use. From now, I would like to talk about new anti-pruritic treatments. New anti-pruritic drug is nadofarine hydrochloride. Remich is a selective kappa opioid receptor agonist, and another is apreptant, a neurokinin 1 receptor antagonist. Nadofarine hydrochloride, named the Remich, is a selective kappa opioid receptor agonist. Activation of mu opioid receptors induce itch. On the other hand, activation of kappa opioid receptors induce the suppression of itch. This drug, Remich, is effective intractable itch of hemodialysis patients and cholestasis patients. This drug may suppress itch in atopic dermatitis. This slide shows the epidermal opioid system. Normal keratinocytes express mu opioid receptor and beta endorphin, and kappa opioid receptor and dynorphin also expressed. In atopic dermatitis, kappa opioid system is decreased. So as a result, mu opioid system is inducible, the itch is dominant. As a result, itch is induced in atopic dermatitis. The Remich nadofarine activates the kappa opioid receptor and dynorphin, so they're effective in keratinocyte, in atopic dermatitis itch. Thank you. Paul showed that pruritus of atopic dermatitis was suppressed with topically applied mu receptor antagonist. These findings suggest peripheral opioid system may be one of the targets for pruritic therapy of atopic dermatitis patients. Apreptant is an NK1 receptor antagonist, and substance P is a major mediator of pruritus. Apreptant inhibits substance P induced itch and significantly decrease chronic itch, which does not respond to conventional treatment with antihistamine. In conclusion, epidermal hyperinnervation is caused by an imbalance of nerve elongation factors such as NGF and repulsion factors such as semaphorin 3A. Second, semaphorin 3A may be one of candidates for antipruritic therapy on atopic dermatitis patients. Third, antipruritic drugs such as Remich and apreptant may be effective drug for atopic dermatitis patients. This is a member of each group, our department. Thank you for your attention.
Thank you for a nice and interesting presentation. Maybe some questions for audience? No, thank you. And now I introduce our next speaker, Dr. Skaidra Valiukeviciene from Lithuania. And topic of speech is skin biological markers associated with diabetes. Thank you.
Dear chairpersons, dear ladies, gentlemen, and colleagues, thank you very much for the kind invitation to the Congress. Today I am going to talk about skin markers and their imaging diagnostics among diabetic patients. Skin manifestation of diabetes mellitus generally appear with the development of disease, but in some cases they may be the primary disease manifestations. Many studies show that dermatosis were more common in diabetics, as you know, than non-diabetics patients. At least from 30 to 70% of patients with diabetes have skin involvement. The mean duration of diabetes for most of dermatosis was found to be between 6 and 9 years, and most of diabetic complications were seen later, within 9 and 13 years. Non-enzymatic glycosylation of dermal collagen and mucopolysaccharides are leading to various cutaneous manifestations and complications. Skin infections occur in 20% to 50% of cases with poorly controlled diabetes, especially type 2. Related factors may be hypohidrosis, diabetic angiopathy, and neuropathy, decreased phagocytosis, impaired leukocyte adherence, and delayed chemotaxis. As you know, fungal infections are the most common, followed by bacterial and viral infections. Diabetic dermopathy, purpura pigmentosa like shin spots, is the most common cutaneous lesion in diabetes, followed by rubeosis diabetica, more prominent in fair-skinned people with diabetes type 2. Good diabetic control may improve the erythema, which is usually located on face, neck, hands, and feet. Acanthosis nigricans has been established as skin marker of diabetes and is usually seen in situation of insulin resistance, such as type 2 diabetes or obesity. As you know, 2 necrobiotic disorders are associated with diabetes. One of them, necrobosis lipoidica, is mostly located on legs. Another, granuloma annula, is also located on extremities, but usually seen in children and young adults. The association of necrobiotic disorders with diabetes is not clear yet. Patients with vitiligo, lichen planus, and psoriasis are reported to have an increased incidence of abnormal glucose tolerance or diabetes mellitus. At least of 25% of patients with diabetes have diabetic foot. Neuropathy and microangiopathy have been identified as major risk factors of diabetic foot. Epidermis of plantar skin becomes thinner and soft tissue stiffen in the presence of diabetic neuropathy, which increases the risk of tissue breakdown and foot ulceration at sites of abnormal pressure, such as prominent metatarsal heads, medial and lateral plantar surfaces. Foot ulcers account for significant morbidity and mortality in diabetics and are responsible for about 70% annual lower limb amputation. Diabetic foot examination includes a lot of clinical, vascular, and neurological tests such as pulse palpation, Doppler, monofilament test, and other, but some of them are not informative enough or are difficult and can be made only by professionals. Therefore, I would like to devote more attention to non-invasive imaging techniques, dermatological techniques such as tomography, ultrasonography, and capillaroscopy, and show what we can expect with them for monitoring of diabetic foot. Infrared tomography is promising technology for monitoring skin temperature and diabetic foot. Recent studies show that no difference in mean temperature between diabetic foot were found without complications. Just in opposite in diabetic patient with callus, neuropathic ulcer, skin temperature at specific region is higher than 2 degrees Celsius compared with healthy foot. As you can see, this table summarizes results of ultrasound studies performed on diabetic foot. The results show that the inflammation within callus in diabetic foot, changes of epidermal thickness, also size and depth of ulcer could be measured very specific and sensitive by ultrasound. Dermatoscope in magnification 10 times or higher could be an additional optical imaging tool for the investigation of capillaries undergoing different changes due to diabetic microangiopathy. As you can see, nail fold capillaries are distributed regularly in healthy subject. However, they are enlarged and distributed irregularly in diabetic foot. Under the 7 Framework Project, we performed skin detector clinical study to determine significant skin markers of a diabetic foot, changes in skin epidermis, thickness, temperature, and capillaries by using ultrasound, infrared tomography, and dermatoscope. In the first stage of this study, we included 28 diabetic patients without visible signs of diabetic foot and 13 control subjects. The second task of skin detector framework is to create and validate novel smart diagnostic technique for thermal, ultrasonic, and optical skin imaging and monitoring of diabetic foot. 10 technical and medical partners from 7 member states are working on this project. In the picture, you can see methods used in skin detector study. Plenty feet of all included subjects were imaged by experienced dermatologists using an infrared camera and high-frequency ultrasound. Also, nail fold capillaroscopy and Doppler sonography were made. These slides summarize our obtained images. Thermal image of plantar foot, nail fold dermatoscopical picture with capillaries, and ultrasonic image of epidermal thickness on the first distal metatarsal head. The lower picture demonstrates measuring of peripheral nerve conduction by our colleagues neurologists. In the picture on this slide slides you can see estimated mean of epidermis by ultrasound on the left and right plantar feet in control subjects and diabetics. We found that plantar skin epidermis is significantly thicker in diabetic foot without visible complication than in foot of control subjects. Correspondingly, no differences in mean temperature between diabetic foot without complication and foot of control subject were found. Higher number of capillaries in diabetic patient could be due to new angiogenesis in consequence of a long-lasting microangiopathy. Our results show that normal capillaries are more common in control group, just in opposite pathologic capillaries, dystrophic, tortuous, or dropout are more common in subjects with diabetes. Peripheral neuropathy was found in 20% of control subjects and diabetic neuropathy in 44% of diabetic patients. Therefore, we analyzed controls and diabetic subjects in one group. Peripheral neuropathy was significantly associated with older age of the subjects, decreased velocity of conduction in peripheral nerves, and thinner skin epidermis on foot on the third distal metatarsal head. In conclusion, infrared thermography, ultrasound, and dermatoscopy could be optimal tools for non-invasive monitoring of diabetic foot in future. Knowledge of dermatological manifestation in diabetics may help for us in early diagnosis and management of diabetes. Thank you very much for your attention. Best greetings from dermatologists of the Department of Skin and Venereal Disease of Lithuanian University of Health Sciences, and best greetings from my home city, Kaunas. Thank you.
Thank you. Maybe a question from audience? No? I would like to ask one question. In your study, it means that as a dermatologist can measure foot skin and then say to my client that maybe you have diabetes?
No, it is not true, but ultrasound could help for monitoring of diabetic patient. For example, patient has a diabetic foot, and very often he could have also ulcer, and changes in thickness and temperature could be message for doctors that they must be in attention.
Thank you. And now, Dr. Strubins.
Dear Skaidra, Professor Valukievic, it is my pleasure to give you honorary member certificate of honorary member. She is professor and chairman in Kaunas and also president of last 11-hour Baltic Congress. Thank you about your input.
Okay, now I would like to introduce our next speaker, Philippa Nyberg. She will talk a very interesting presentation today and also tomorrow. Early morning, please everybody come to work to course of autoimmune dermatosis. Please, Philippa.
Good morning, dear chairman, dear chairpersons, and dear Professor Rubins and dear colleagues. Thank you so much for inviting me here to Riga. The small course tomorrow morning, I would like you to email me if you are coming, because there will be some handouts if you are not too many. So the topic of this lecture is absolutely impossible, as everyone understands. What's new in autoimmune diseases in the skin? We could go on for hours, and I guess you are all quite tired. But I have just chosen a few interesting things that I might share with you today. Oops. Well, which one? Skyda, can you show me? Gets black. Aha! No, this one. Okay. So this. Thank you. Thank you very much. Okay, so autoimmune diseases in the skin, they happen when we have an autoimmune reaction. Instead of external stimuli like bacteria or viruses, they turn against the skin, our own defense. And this is just a small picture depicting all of the different syndromes like multiple sclerosis, psoriasis, inflammatory bowel disease, rheumatoid arthritis, and asthma, and all of the substances that we can eventually direct medicines to, because that's our ultimate goal. So I want to go through autoimmune blistering diseases and a little bit about the collagenoses, especially dermatomyositis and cutaneous lupus. In the autoimmune blistering disease, I would like to point your attention to the mortality. How do our patients survive when they have autoimmune blistering diseases like bullous pemphigoid and pemphigus vulgaris? Well, this mortality figure shows blistering diseases, and the highest is 10, toxic epidermal necrolysis. The mortality has gone down within the last 10 years. But the other figures show actually an increasing mortality, especially in bullous pemphigoid, and a little bit decreasing in pemphigus. There were two interesting papers recently that I would like to encourage everyone to look up. It's in Autoimmune Reviews, Diagnosis and Classification of Autoimmune Blistering Diseases, and Diagnosis and Classification of Pemphigus and bullous pemphigoid especially. And why is that? Well, because now when the more sophisticated methods we have to measure these diseases, the more we can also learn how to direct our therapies. So it's valid to have criteria for diagnosis. As we all know, we first can divide in an algorithm between intraepidermal and subepidermal blisters. And then we find, of course, in the intraepidermal, the pemphigus, and the subepidermal, the pemphigoid disease. And then with different ELISAs and also reagents in immunofluorescence, you can get by a very specific diagnosis and direct your therapy to that. I will not go further into that. In bullous pemphigoid, characterized by blisters that you see because they are tense and they are subepidermal, with a characteristic histology, subepidermal blister with eosinophils and the characteristic immunofluorescence pattern, very itchy. And here you can see an example in an old woman. And you can go for years without a good diagnosis if the blisters haven't come. And in Olmsted County, which is a county in Minnesota quite similar to Sweden because the population there have emigrated from Sweden to a large extent. So we are very interested in their epidemiology, and they keep looking at the dermatological diseases. So now they have looked at bullous pemphigoid from 1960 to 2009, and they found 87 patients during these years, and they looked at age and sex-matched controls, and they found an incidence of 2.4 per 100,000, little less than cutaneous lupus. The incidence increased with age, as you can see here, age at diagnosis. So at 90 years, there were much more patients, and you can also see that men were a little bit more common in the older age groups than women. And this picture also shows how women and men had a higher mortality than the expected mortality rates. So the observed mortality rates in bullous pemphigoid was quite a lot higher than in the control population. And then another interesting work has looked at recurrence of bullous pemphigoid. Why do they recur? Some patients go on to remission and some of them recur. Why is that? They looked at 120 patients with a female to male ratio at 1.3. Extensive disease in 53 patients and mucosa symptoms there. And what they noted, which was quite interesting, was that 57 of them, 47%, had also neurological disease, like dementia, Alzheimer's, stroke, and Parkinson. Also, some of them had malignancy, and the first-line treatment was local therapy with potent steroids or methotrexate. So they found that when they looked at multifactorial analysis, that extensive cutaneous involvement and dementia were predictors for recurrence in these patients. And other risk factors were if the anti-BP180 autoantibodies were over 23 U per milliliters on day 150. They found a very strong significance there, meaning that if you measure those autoantibodies, you could actually predict recurrence in your patients. What was also noted was that they had a high rate of success only with local potent steroids alone, without any systemic medicines. And they also saw a reduction in the autoantibody levels only on local treatment. They also have a hypothesis in this that the neurological diseases could actually be linked to the pathogenesis of bullous pemphigoid, with the antigen being linked to the neurological system, which is interesting for therapeutic reasons in the future. In pemphigus, we found these much superficial blisters where we rarely see the blisters themselves, also with a lot of mucosal involvement and the typical intraepidermal blister with acantholysis. In a recent and very comprehensive review in Clinics in Dermatology, you find an interesting algorithm of treatment from the pathogenesis, where we know quite a lot of that now, with the production of desmoglein reactive antibodies directing the phenotype of the disease. There they also state very clearly that the state-of-art therapy is azathioprine and high-dose steroids. But in about 20 to 30% of cases, you will not succeed with that, and then you can go on to rituximab. This is the first report of rituximab in pemphigus patients, with healed patients after 6 and 12 months of therapy, also responding to the antibody titers, and that has also been done in larger population studies. But this is a second-line therapy if you don't succeed in the first line. In connective tissue disease, I would just like to point out a popular treatment of vulvar lichen sclerosis, tacrolimus, has been compared to superpotent steroids, clobetasol propionate. This is the algorithm. I will not go into that, but this was a double-blind study evaluating the two creams for 3 months. And they had 58 females with newly diagnosed LSA of the vulva. 55 patients were included, and 28 to steroids and 27 to tacrolimus. And really, after this time, 3 months, 28 patients still had symptoms. But 19 of the tacrolimus patients still had symptoms, while only 9 of the steroids. So the steroids worked quite a lot better. And 15 patients were in remission, 15 of 28, which was much better than the tacrolimus, which is worth noting. And then, I still have time, yes. In dermatomyositis, this is just a picture of the heliotrope flower which is supposed to be the color of the eyelids in this disease. The patients can often look only like that, not so much like the flower, but they have the typical finger lesions, the photosensitivity very similar to that in cutaneous lupus erythematosus, and also here on the fingertips. The association to malignancy is very well known. However, this can also be true to cutaneous lupus, as we have shown in Sweden. During the last years, there has been emerging knowledge about special autoantibodies in dermatomyositis, and there have been attempts to link special clinical pictures to the autoantibodies. This is not really pinpointed yet, but there are hopes, especially on one autoantibody that I will show you now. And this is the MDA5, the cadm autoantibody, which is linked to the amyopathic dermatomyositis, formerly called dermatomyositis sine myositis, or amyopathic dermatomyositis. This gene is linked to melanoma differentiation, and it's associated with cutaneous ulceration, palmar papules, and oral pain, and also with a very severe cutaneous vasculopathy. But they may not have myositis, but they are at large risk for a very grave interstitial lung fibrosis. So here are some of the clinical symptoms linked to this special autoantibody in dermatomyositis. The fingertips, the ulcers especially. And here are some more pictures of that. Fingertips ulcers, you should look out for that, and also a very severe vasculopathy, and maybe take especially x-rays of the lungs in these patients. Now in lupus, these are old pictures that I always show, but I think it's relevant to show that we still are looking for these 5 questions on the picture. How common is this disease? What risks are there? These are the questions that the patients ask themselves. How should we treat it, and what is the prognosis, and why did I get this disease? We are talking about the LA-specific skin lesions, the very well-known butterfly eruption, the subacute cutaneous lupus connected to the Rho SSA autoantibodies, and the chronic cutaneous lupus that is still much, to a very large extent, discoid lupus, but also other variants that are less common. And the ratio is still that cutaneous lupus is about 2 times more common as SLE if you take all subtypes, and subacute cutaneous is about 20% of the whole cutaneous lupus group. This is a picture that we would like to get rid of in 10 years from now. It's a very complicated classification, and I will not go into deeply because my hope is that we are reclassifying this. The work has started internationally from a group in Philadelphia. But there are a lot of overlaps. You can see that subacute cutaneous lupus, for example, 50% have and 50% have not cutaneous disease. Discoid lupus, well, they are mostly cutaneous, but how do we know when they are systemic? And we have looked at cutaneous manifestations and serological findings in 260 patients with systemic lupus just to find out what the overlap is. And this was in Stockholm, and I will just briefly show you, compared to other older studies, that in our 260 patients, we found butterfly eruption in only 4% compared to 51% in earlier studies, and that is because we made from acute cutaneous lupus histology verified, whereas malar rash, we had the 53%, meaning that if you only go by history, you will find the malar rash, but that's very inspecific and can be all sorts of other dermatological issues. So for the prevalence and incidence of cutaneous lupus, we have to go to outpatient registers, which is not so common in the world. But we fortunately have them in Sweden because we are not so large population, and then we could do a large study from 2001 to 2007 in Sweden, and the incident cases are stabilizing here in the last 3 years of the study. And then we could see that 75% of our patients were female, and that 80% about were DLE, and subacute were only 15%, and green is the other local LE, like tumidus and hypertrophicus and so on. So discoid and subacute are the main two subtypes. And the whole incidence that from our Swedish and also confirmed by Minnesota Olmsted County is 4 per 100,000. You can remember the figures for bullous pemphigoid, so this is double as common. And 10% progress to SLE in 1 year. This is just a picture that for men and women, it was a little bit higher risk for males to progress to SLE in our cohort. And recently, this study has been redone in Philadelphia by Vicky Worth and co-workers. They made a study from 2007 to 11 with 13 patients in their group progressed to SLE, that is 17% of their cohort, and it took them 8.3 years to progress. But 4 of these 13 patients that progressed only met mucocutaneous and serological ACR criteria. So they had ANA and mouth ulcer and photosensitivity. So they were not very badly hurt in their SLE. They did not have nephritis, for example. So their conclusion was that even if the cutaneous lupus patients do develop SLE in a percentage of about 20%, dermatologists could still, in the most of cases, go on looking at them, but it's important that we monitor for SLE. And another thing that we should monitor for is subacute cutaneous lupus and drugs, because it seems to be very much more common with drug-induced subacute cutaneous lupus than we have previously thought. We have made a large study in Sweden, 234 SLE subacute cutaneous cases, and we linked it to our registers in pharmacological side effects, and we found that antifungals, biologics, antiepileptics, and proton pump inhibitors especially. We did not find thiazides in that study because of too few numbers of patients, but it's very well known that also thiazides can cause drug-induced subacute cutaneous. So 38% of subacute cutaneous lupus were shown to be caused by drugs, and that's quite a large extent, so you should always look for that in your patients with subacute cutaneous. And finally, I just would like to point out that SLE is a very serious disease, and we should not neglect it in our patients. There is a new treatment for SLE that is gradually going on to dermatological indications too. That's Benlysta, belimumab. It's a human antibody against IgG1. And the side effects you can see here. And this is just a picture to show how the indexes from rheumatological point of view went down in a study from 12 months of Benlysta to SLE patients that were therapy resistant to all other therapy. And their side effects were bearable in these patients. You see that headache, for example, is quite common, but it's of course curable. So that has shown promising results also in skin symptoms. But the picture I showed you in the beginning with the very terrible classification we have today is so complicated that it isn't used in rheumatological studies of their medicines. And that creates a large problem for our patients because we don't know the endpoints for the skin, which we should do something about. Finally, I have just caught a picture from also Vicky Worth in Philadelphia. They have treated 5 patients with lenalidomide, which is a new successor of thalidomide with less side effects and very good results measured by CLASI and quality of life in cutaneous lupus patients if you don't succeed with the normal antimalarial treatment that all patients, of course, should try. And I thank you so much for your attention.
Thank you, Philippa, for your nice presentation. And I think that tomorrow in the early morning at 9 o'clock, those who are interested in this topic are kindly asked come to a session where we talk about these autoimmune diseases.
And I will also talk a little bit more slowly.
Okay. And now I ask Professor Rubins.
Yes. Dear Professor, it's my pleasure to hand you honorary member of Baltic Association about your input in our association. She was lectures many times in Latvia and also organized course. Thank you.
And now we finished our session, and after some minutes at 5 o'clock here in this hall will be opening ceremony. Thank you.